All right, let's kick off our lunchtime event. We have to finish up by 2. It's an honor to present everyone, and I'll give you a little of the backstory. So when we were in Sierra Leone, Justine really pushed us very hard to come up with some novel key messages. So we had met in January, and we came to Sierra Leone, and we reported out from our working groups. And she said, well, that's great, and you guys have done a lot of background work, but you really need to come up with some new key messages, and that's going to require research and modeling. And we all took a deep breath and thought, well, it's June now, and we have to submit this in September or October. We weren't really 100% sure how we were going to do this. The group that we have here was the most collaborative, fastest working, smartest group I've ever worked with. And what they accomplished from June to September or October is absolutely miraculous. And it shows through. They essentially populated our key messages and more, plus papers in the Lancet Global Health, plus papers in multiple other journals. I honestly cannot believe what you all did in that period of time. So let me just introduce them quickly to you, and then I think some of them have some presentations, and you'll be very interested to see how they arrived at the models and the key messages and where those came from. So Tom Weiser from Stanford University. Tom is sitting right down here. Mark Shrime from Harvard here. Blake Alkire, also from Boston. Nakul Raykar, another one of our global surgery fellows from Boston. Steve Bickler from UC San Diego. Steve's down at the end. Stephane Verguet from Harvard. So that was our core modeling group. We met via Skype every Thursday at about 3 o'clock from June until September, and it was a frantic pace. So, gentlemen, thank you, and I will turn the baton over to you.
Good afternoon. Blake and I are going to double team this this presentation, really relating to our first key message for the Commission, answering the question, how many people worldwide lack access to surgical care? To answer this question, we really had to ask another question, which was, what do we mean by access? So the Commission defines access by its vision statement, saying universal access to safe, affordable, and timely surgical care. And that definition of access encompasses at least 4 dimensions. Timeliness, that you can get to a surgical facility in a reasonable amount of time frame when you need it. Capacity, in that when you get there, there's a surgical team in an operating room, and the capacity to provide surgical care. Safety, in that the care that you receive is relatively safe. And then finally, affordability, so that you can get care and not be bankrupted by it. Blake's going to describe how we modeled that.
So to answer this question, we actually started by asking how many people do have access to surgery. So for each country, we constructed a chance tree that really just in essence incorporates the probability of each separate access dimension being available to an individual in a country. And from the chance tree, what we are able to take away is the joint probability that all 4 access dimensions, affordability, timeliness, capacity, and safety, are available to an individual. And once we have the joint probability, it's just some simple multiplication to figure out both who does have access and who does not have access in a country of interest. So obviously there are no perfect measures of the access dimensions that we're interested in, so we had to employ proxies. In going about choosing which proxies we would implement, we had basically 3 overarching criteria. The data had to be available and accessible. It had to be what we felt was a meaningful estimate of each access dimension. And it also had to be conceptually consistent with our model. So ultimately, for our baseline or headline results, these are the decisions we made for our proxies. For timeliness, we chose the proportion of road traffic injuries that have access to an ambulance from WHO data. For capacity, we relied on surgical procedure volumes and constructed a ratio of current procedure rates to necessary procedure rates, which actually you'll hear more about in a later key message presentation. For safety, we used a proportion of operating rooms with pulse oximetry. And for affordability, we used the proportion of individuals that would be at risk for catastrophic expenditure. And that's another model that you'll hear about very soon. So because this is a model, we felt it very important to represent the inherent uncertainty in our estimates. And we really did this in 4 ways. The first is that our baseline results actually have 2 sets of estimates. The first estimate, which we're calling the full tree or the full model, applies all 4 access dimensions to the entire population of a country. The second, which we're terming the selective model, applies all 4 access dimensions to rural populations, but assumes that urban populations, that 100% of that population has timeliness and capacity available to them. And so really the selective model is a lower bound estimate. We also reran our analysis with the exclusion of each access dimension. So for example, we ran it with capacity, safety, and timeliness, and excluded affordability to understand how each access dimension contributed to our results. We also reran our results with different proxies to see how that changed our results. For example, operating room theater density as a measure of capacity. And then finally, to account for the uncertainty in the parameters themselves, we ran it with probabilistic sensitivity analysis.
So the results we've now seen featured a couple of times today, and they're in the booklet, and we're running out of time, so we'll kind of breeze through this. But there's a total global population of about 7.125 billion people. And with the full tree, applying all the proxies to all populations, we find that 5.3 billion people lack access to surgical care. If we use the more conservative estimate, we get a number of 4.8 billion people without access. These differentials in access are, of course, borne heaviest on the lower resource settings of the world, and you can see in lower middle-income countries and low-income countries, nearly the entire population is without access to safe, affordable, and timely surgical care. This is a geographic representation of the same, and you see that Sub-Saharan Africa and South Asia are particularly affected by this issue. As Blake was talking about, one of the key parts of this sort of modeling analysis is to make sure that the model itself is stable to the various inputs that we're putting in, and that not any single part of the model is influencing the results all too much. And so we excluded each one systematically to see how that would impact our results, which can be used as a measure to demonstrate the stability of the model, but also as an opportunity to if you don't believe any specific aspect of this and you want to see how that would affect the overall results, this does a pretty good job telling us that. So we're going to start with the baseline, 4.8 billion for the selective tree. And if we exclude timeliness and essentially say that everybody in the world has access to timely surgical care, 4.7 billion still do not have access to safe, affordable surgical care. If we exclude capacity, 4.6 billion. If we exclude safety, 4.3 billion. And lastly, if we exclude affordability, in essence saying that we provide financial coverage to everybody in the world, there's still more than half the global population that does not have access to surgical care. So in conclusion, at least 4.8 billion are without access to surgical care, and just note while we say that is very much a conservative estimate. This doesn't include access to chronic conditions or the challenges related to pre-hospital care or the decision to even seek care for the billions who know that they are not going to be able to afford it. The burden falls most heavily on the world's poor, particularly the rural poor. And scale up clearly will require more than just one particular aspect of access. Clearly, timeliness, safety, affordability, and capacity all play a role. That's pretty much it.
Are you going to take questions?
Yes. Absolutely.
What made you to use oximetry as one of your processes?
Great question. We felt that pulse oximetry is a necessary requirement for safe surgery, but we would readily admit it's not a sufficient requirement. So it doesn't, an OR that has pulse oximetry doesn't necessarily have all avenues available to it to practice safe surgery, but we said, okay, then that makes it a more conservative estimate. So it's an indicator, but it's also conservative.
Could you share with us what other indicators you might have used?
Well, we considered perioperative mortality rates, which unfortunately the data were just not available. Those are sort of the two contenders, actually. The latter, the perioperative mortality rate, would have done a nice job of actually capturing, I think, multiple levels of safety, but unfortunately it's just not available. And I will also readily admit that the pulse oximetry data was useful because it was available on a global scale. Yes?
You talk about global population of 7 billion. My understanding of UN data population projections in the future is that population is likely to increase to somewhere between 11 and 12 billion in the next 50 years or so. Almost all of that increase is in sub-Saharan Africa and largely attributable to differences in fertility rates in sub-Saharan Africa compared to everywhere else. So did you do anything on forecasting future changes in terms of, if we've talked about cesarean sections and access to obstetric care, which may be there now, it strikes me that it's going to be awful in the future.
It's a great question. We did not, but I see that as definitely a future avenue for research. Thank you.
What's the use of timeliness and use access for an ambulance from an RTA? Is there any evidence out there looking at particularly rural communities? The messages that came from earlier was access to primary level district hospitals, or even not going to see traditional healers first, education, communication, that kind of thing. Was there any evidence out there to support that as well?
I think that that's a great point. I think that this model does not include any aspect of the 3 delays or the challenges that face individuals seeking care besides what was actually modeled. So the decision to seek care itself is a major part of this entire equation, which is not captured. The affordability, or the decision to not seek care because of affordability, is also not captured. The lack of timeliness of achieving, of getting a surgical procedure, which is a chronic condition, which may not be available to you because when you reach the hospital, they're flooded with acute emergencies. That is also not captured. So I think that the overarching message is that even when we're not dealing with those very important issues, 5 billion people still don't have access.
And we'd love to take more questions, but given that we only have 30 more minutes, I would like to turn it over to the next team. We have a poster as well, and you can find us, and we'd be happy to answer any questions you may have. Thank you so much.
Hi, my name is John Rose, and I'll be, well, first I want to start by thanking the commissioners and the chairs of the commission for inviting us to share our research. And I want to acknowledge as well the presence of Drs. Weiser and Bickler here, who are co-authors on this work. I'll be briefly summarizing the modeling methodology in support of key message 2, where we estimate the need for surgical procedures worldwide. Our objectives were to estimate the minimum total need for surgical procedures in the world, and then the gap between the total need and the current output, or what we call met need. First, we needed a benchmark population where we could determine the ideal volume or rate of surgical procedures that meets the need of a population. There's no ideal, there's no perfect setting in which to conduct such a study. However, we chose New Zealand as a benchmark setting for the following reasons. In New Zealand, there's a far-reaching nationalized healthcare system. There's a centralized, quality-controlled database of ICD-coded clinical encounters. And there are also excellent population health outcomes with comparatively low cost. For example, life expectancy in New Zealand is comparable to its high-income country peers. The same is true of maternal mortality and under 5 mortality, and this is achieved with a total health expenditure that is roughly $1,000 less per capita. Having chosen a benchmark setting, the next step was to calculate surgical incidence within that population. To do that, we extracted all hospitalizations from the New Zealand National Minimum Data Set between 2008 and 11. We organized or categorized these hospitalizations by the primary cause of admission, according to the disease state taxonomy of the WHO Global Health Estimate, which is quite extensive. We then queried each hospitalization for the presence or absence of a surgical procedure, defined as anything requiring general or neuroaxial anesthesia. This is a very conservative definition. I think a consistency that you'll find between these presentations is that we erred always on the side of conservative for our estimations. We then calculated the disease-specific surgical incidence by dividing the volume of surgical procedures in a given disease state, I, by the volume of diseased person years for that disease state. We then standardized those incident rates of surgical procedures and calculated the cumulative estimated need for surgical procedures for the world by multiplying the incident rates of surgical procedures for disease states by the prevalence of those disease states for all other countries of the world. The population level estimates of burden of disease were obtained from the Global Burden of Disease Study 2010. We then compared from those equations the total surgical procedure need to current or updated country level estimates of surgical output using the same methodology that Dr. Weiser published in the Lancet in 2008, but with updated data from 2012. I won't go into these extensively, but these are now in press and were used as a part of this modeling strategy. Lastly, we estimated the gap between the total procedure need and the met procedure need by making a fundamental assumption, which is that when a surgical procedure is provided, it was the appropriate procedure. It's a big assumption, but with that limitation, we can still estimate the gap conservatively. We estimated the unmet need at the level of the GBD epidemiologic region because the Global Burden of Disease Study aggregates country-level data to regional levels based on epidemiologic and demographic similarity between countries. These methods are available in the appendix of the GBD study. Our results from New Zealand showed that surgical procedures are required in all disease subcategories of the global health estimate, shown here in order, decreasing order of frequency as you go down. The orange represents the proportion of hospitalizations whose care required surgical procedures, and the gray represents the proportion of hospitalizations that did not require surgical procedures. Using these data, specifically these volumes here, we extrapolated to create estimates for total minimum need, presented here, for each of the GBD epidemiologic regions. Interestingly, the absolute procedure volume here in this column varied substantially by GBD region. Evidence, for example, in Eastern Asia and Southern Asia that were outliers, mostly based on underlying differences in population size. However, after accounting for population size, the rate of procedures per 100,000 population within the regions also varied significantly. Seen most clearly by comparing Central Latin America here to Western Sub-Saharan Africa here, with a twofold difference that represents underlying difference in disease burden driving discrepant need for surgical procedures. Lastly, we tabulate here total minimum case need here in this column, met need with the assumption that I mentioned, and then the minimum estimated unmet need in absolute and rate terms. Most importantly, we found that 12 of the 21 regions had substantial unmet need, and that when tabulating the absolute surgical procedure volume, we arrived at the 143 million surgical procedure estimate for the world. Additionally, these numbers allow us to appreciate the degree of depravity in some regions. For example, in Western Sub-Saharan Africa, 21.8 million surgical procedures were needed in 2010, but only 2.9 million were provided, roughly 13%. In conclusion, we say that surgical care is needed in a broad spectrum of disease states. A large unmet need exists in 12 of 21 regions of the world, which, by the way, is where 75% of the population lives. And, more specifically, that the regions in sub-Saharan Africa have the greatest rates of unmet need. Thank you. Any questions at this time? Yes?
I'm surprised. I saw that Andean Latin America, so there was a zero. Everything was being met for that region. Were all Andean countries being considered, or only a few?
No, all of them are considered, but they're broken down into regions. We can talk about it later, and it's also in the publication. But actually, I can't go back. Oh, there it is. So they're broken into regions: Central Latin America, and then Andean Latin America. And where the zeros occur here, it's based on the fact that there was no unmet need. So I'm not accounting for surplus. I could have shown a negative number there, but that wasn't really the purpose, and that's getting a little outside the parameters of the limitations. But that's what that zero means. Yes?
How do you think the fact that within a given country, certain populations may have different rates of need for surgical intervention for a particular diagnosis, like peptic ulcer disease? In one country, or even within a country, high-income folks may never require surgery for that, whereas folks that have challenges with access, no money, no care, may actually need surgery for that. So within a population, there's different rates needed. So between countries, people with the same disease, that population may have different rates of surgical need. How would that affect, like, is this a conservative estimate, overestimate? What would that do for your model?
That's an excellent question. So the answer is it's a conservative estimate, because what we know is that the level of surgical, we've actually had Lars, who's here, do a study looking at the rates of surgical procedures for infectious disease categories in Sweden versus South Africa, where that disparity in prevalence exists and the disparity in access also exists. And the reason it's conservative is because the number that requires surgery is higher in the lower income settings. So by choosing New Zealand, we actually made ours a conservative estimate in that way. But you bring up an excellent point, and that's why we also recommend continuing this analysis at both the national levels and then the subnational levels as well, to really get down to the more granular layer of need. Does that answer your question? Okay. Yes, please.
Some of these calculations, like in New Zealand, it's the demography of the need of surgical procedures, especially related to orthopedics, that you would find, fragility fractures or joint surgeries. Now, that's just a comment of what is one of the limitations. But the second thing is that if you were to take this to a specific country to understand the need of that particular region, how would you go about it?
That's an excellent question. So there are a couple different steps that we have to undergo to get to where you want to go. One would be to use different benchmarks. So there are limitations with using New Zealand, as you mentioned. There are many more, actually, that we haven't mentioned. But we need to perform the same analysis for multiple countries at different levels of the income spectrum. So we know, for example, that Sweden provides a different rate of surgical procedures than does New Zealand. One of the reasons we chose New Zealand is because amongst high-income countries where we have data sets to work with, they're at the lower end of the spectrum in terms of how many surgical procedures they have per 100,000. So again, we erred conservatively there. But nonetheless, the studies need to be done in the way that you're describing. However, notwithstanding the limitation of data access, we have actually prepared country-level estimates for the country of Zambia. And I don't want to jump the gun and steal someone else's thunder, but that's actually on our minds and a part of a presentation that will be given later tomorrow. Yes, please.
On a country level, how do you think the distribution of where surgical procedures are provided, for example, in an urban setting where perhaps the need isn't actually there, sort of impacts these estimates?
I think it impacts them to the extent that countries are not homogeneous in terms of the urban and rural breakdown. It's been almost 5 years now since globally we transitioned from a predominantly rural world to a predominantly urban world. I think as we move closer towards an urban setting society, that it becomes a little bit easier to make that jump or that assumption, but it's definitely something that has to be worked out. Now, for New Zealand, in our benchmark country, they have a substantial number of clinical procedures that are performed in rural settings because of their nationalized healthcare system, and we were able to capture those. And by not including private sector procedures, by only including the nationalized healthcare system, we hoped to bias on the conservative side of those kinds of estimates. Okay, I'm going to pass the baton to the next group of presenters.
There it is. So my name is Mark. I have a lot of math to go through in 5 minutes, so I'm going to talk really quickly. But stop me if anything starts to get a little bit too quick. So this is key message number 3. Before I get into the actual key message, let me just acknowledge my co-authors, all of whom I think I saw in the room right now. I have no actual conflicts of interest to disclose related to this project. So what I want to do is I want to give you the background of the question that we're trying to answer with key message number 3. Excuse me. Some methods we use to get to those answers and then the results themselves. We've known since 2007 that 150 million people face financial catastrophe every year from medical costs. This is from a paper by Shu in Health Affairs Millwood. We don't know 2 things. We don't know how many of those come from surgery, and we don't know how many more of those come from getting to care, transportation, food, lodging, et cetera. Those are not actually counted in these 150 million. So those are the 2 questions that we wanted to answer with key message number 3. To do that, we need to define what we mean by catastrophic expenditure. We need to figure out how much people are actually spending on surgery, and then we need to figure out how many of them spend more than catastrophic. So there are 2 definitions for catastrophic expenditure, and we chose the first because we don't have data, excuse me, on the second one. The second one is sort of the classic definition of catastrophic expenditure, which we don't have data for around the world. We have data for the first one. So we chose a threshold of 10% of your total income is a catastrophic expenditure. We also don't know how much people spend on surgery. Again, in keeping in line with everything that we've been saying, we chose a conservative measure, which is the cost of a C-section from WHO Choice. C-section is not neurosurgery. Neurosurgery is more expensive than C-section. So this is a conservative measure for the cost of an actual surgery. But with these 2 decisions, we can then count how many people actually spend more than a catastrophic expenditure threshold. So this is the crux of the model right here. C is the cost of surgery. OOP is the out-of-pocket proportion of that cost. And so we want to know how many people is OOP times C greater than T, which is your threshold, times Y, which is your income. So this is the basics of the model right here. With just a little bit of algebra, then, I can say what I really want to find is the number of incomes, the number of people with income that is less than this ratio OOP times C over T, which is relatively simple-ish. For any one country, the expected number of catastrophic expenditure cases is the population of that country, N, times the probability the cumulative probability of having an income that's less than that threshold of OP times C over T. So that's based on F of Y, which is the distribution of your income. But if you think about this, this is actually just the number of people that are at risk for catastrophic expenditure, because not all these people are getting surgery. The people that are getting surgery are here. And that P of Y is the probability of getting surgery, which is dependent on how much you make. Richer people tend to get surgery more than poorer people do. So we have to deal with two things in this equation. We have to deal with F of Y, which is the distribution of your income, and we have to deal with P of Y, which is the probability of getting surgery. F of Y is easy. This 1974, Salem and Mount actually gave us a way to parameterize a statistical distribution to approximate income in any one country. There it is. I'm not going to go into it. But then we have to deal with P of Y. And I don't know how much more likely you are to get surgery if you make $101,000 as opposed to $100,000. But what we do know is the access to surgery by wealth quintiles in a number of different countries. So the richest quintile compared with the poorest quintile. So that's what we've done here. We've broken it down to just quintiles instead of trying to estimate some function of that. That's the end of the math. So what we found with that is that of the 150 million cases of catastrophic expenditure that Shu predicted in 2007, 22% of them, or 33 million, are due to accessing surgical disease. But that 33 million is an underestimate, and if we include the cost of transportation, food, and lodging that are necessary to get to care, you add almost 50 million more people who are actually impoverished trying to get access to care. And this was brought up in one of the previous talks. What this does not do is count the financial burden of a lack of access. This is just people getting access to surgery. Around the world, 3.7 billion people are at risk for catastrophic expenditure. So if they needed surgery today, they would impoverish themselves if they got it. And they live in the places that you would expect them to live in sub-Saharan Africa and parts of South and Southeast Asia. And of those people who are actually impoverishing themselves, it is primarily the poor. Even though the poor get less surgery, they are much more likely to impoverish themselves if they get surgery. This slope, this gradient, is actually pretty flat in low-income countries where the cost of surgery is relatively high compared to the incomes that people are making. And then the gradient starts to get steeper and steeper as countries start to develop. Any questions? Sir.
The question come up in terms of what kind of healthcare systems, in what kind of healthcare systems is this happening? Is the risk of impoverishment higher than others?
So we did not look at that specifically. Some healthcare systems provide universal health coverage. Some healthcare systems provide universal health coverage in quotes, but patients still have to pay a lot of money to get free surgery, and some don't provide it at all. We didn't break it down in that regard. We do know from the World Bank the proportion of a health system's financing that comes out of pocket, and so that's what we actually included in the model. Gavin.
So my understanding from the Shu study, they used a different definition, like 40%.
Correct.
You used the 10%. So I think I may be making a mistake later in one of my slides where I argue that you've shown 33 million out of Jews, whatever.
Well,
I said, well, it seems to be about a bit.
Right.
But it's not completely pairing up with that.
It's not, so the Shu estimate is 40% of your capacity to pay, which is your income minus subsistence, minus food. And there is not necessarily a linear correlation between the two, because in individuals for whom 70% of your income goes to food, your capacity to pay is much lower than that. The WHO does use both definitions as catastrophic expenditure, so even though they're not directly comparable, they're close.
Great, I'm not changing my slides.
Yeah, don't change your slides. All right, well, thank you very much.
All right, sorry for a little pause. Before I get started, let me thank John Mira and his group for including me on this adventure, which was very exciting and very emulating. And also a special thanks to Gavin Yami, who initially linked me up with the work of the commission. So this presentation is about background work we did about estimating or trying to look at scaling up of surgical services, both from the lens of the timing to achieving target, which is the specific target of about 5,000 surgical operations per 100,000 populations, and then meanwhile trying to get at a rough estimate of what would be the cost of achieving that scale up for low and middle income countries by 2030. So the recommended target that the Commission, after some discussions, came up with was to achieve by 2030 about 5,000 surgical operations per 100,000 population. What we did specifically in this paper is to model the scale-up of surgical services in order to achieve that scale-up by 2030, that target of 5,000 per 100,000 population. We focused on about 88 countries, low middle-income countries, with population greater than 1 million. And what we did is that we looked at different scenarios, and I'll come back to this, of scale-up rates or rates of scale-up, and tried to quantify the associated costs with this. So basically, I won't go into equations, but I'm happy to either in questions or later on during the day to talk into more details. In fact, the details are in a paper in Lancet Global Health. What we did basically is we took the volume, the surgical volume that we have today, based on a lot of work that Tom Weiser and his team have been doing, and tried to look at starting from this base, how much we could achieve in terms of surgical operations per population by 2030, looking at three specific assumptions. The first one, looking at secular trends driven by growth rates of countries, and two other case scenarios were actually inspired by real case studies where with two countries, one being Mongolia, which achieved a scale-up in about 10 years of surgical services at about 9% annual rate, and Mexico, which has been extraordinary into scaling up surgical services at a rate of 23% per year. So bear in mind, and I'll come back to this in some of the, I think some of the work forward and some of the concluding remarks is there is, we had very little empirical data about trends in surgical volumes, and we did rely on these two countries, not because we liked specifically these countries, but because indeed they were the two only countries where we had that specific information available. In the meantime, we tried to estimate the cost of scaling up that surgical volume per population, and then in the meantime, as you need to, or as you scale up volume, you will need to build hospitals and operating rooms. So hand in hand with the scaling up of surgical volume, trying to quantify the cost of building additional operating rooms to have this surgery delivered. So the first item is looking at the scale-up or the timing to scale up of achieving that target of 5,000 per 100,000 by 2030. And here what you have is two specific cases. Remember, I was telling you we looked at three cases. The first one is looking at secular trends, which means that you increase 5% annual in terms of surgical volumes. And in that context, what you have here on the figure is on the y-axis is the time by which country, the time by which over a year by which country would achieve the target of 5,000 per 100,000. And in the case of secular trends, you find that about 50% of countries would have achieved target. In the meantime, we did the same for the Mongolian rate of scale-up as well as the Mexican rate of scale-up. I'm only showing here the scale-up for Mongolia rates of improvement. And in this case, what you have is you have about 2/3 of countries that are the countries below that first line here, which is 2030, that achieve the desirable target endorsed by the Commission's work. So that is for the timing of surgical services. And within that, what we associate with this is the cost related to both the surgical procedures as well as the cost of operating rooms constructions. So a few key inputs that we used is first, which was extremely useful, was a background paper on unit costs for cesarean section that was published at the same time, or a background paper for the World Health Report 2010 by WHO, where we had unit costs of cesarean section that we could use for proxies for our estimate of unit cost of surgical volume. That's one. The second one, and I'll come back to this, is what we need is the cost of operating room. And I'll point here and I'll point again. We were faced with extreme scarcity of data. It is absolutely amazing how little we know about the cost of infrastructures in a number of low middle income countries. And I think if the Commission can do a great service, and I'm hoping with some of the metrics that can be started to be collected, I think there would be a lot of thing to be learned in this direction. So we relied a lot on our network, the vast network that the Commission had, to have some estimates through colleagues and so on. In terms of some of the findings, I'll just focus on so the total costs, and I think it's useful to think in terms of annual costs. The total cost that we found for the period from today to 2030, or we had an anchor at 2012, is from about 15 billion to 30 billion, depending on what kind of rate of scale-up do you assume. The higher, the more expensive, and so on. I'll point to one thing, a few particular figures here, is the case of, which I think is, the Mexican rates might be a little too ambitious, but rates like the Mongolian rates of scale-up, about 9% annual, one can argue can be achievable. And in that case, what we find is that the expenditures as compared to total annual health expenditures range from about 8% in low-income countries to about 1% in upper middle-income countries. A few concluding remarks. At least 3 lessons I think we got from this work is that surgical scale-up, the costs is substantial, but when you think about it, is actually affordable if you compare at least some of the benchmark estimates we had from some of the estimates from the Lancet Commission on investing in health. That's one first thing. The second, and perhaps the most important, is that one should realize that we have an extreme scarcity of data on which not only we do these estimates, but also I think hopefully opens the door for a substantial agenda of work ahead of us. In particular, hopefully the Commission is only the end. It's only the end of the beginning, and there's questions around human resource capacity, quality. Already, a question was asked about distribution, the subnational versus national. Of course, lots of capacity in cities, but what about rural areas and so on? So there's lots of work to be done in the years ahead. Thank you very much. Few questions? Yes? I'm sorry?
Is there any other, did you find any papers or any comments on what's got to, what you've got to give up to afford this? So you say it is affordable at the expense of what in-house. Is there anything that might be?
So if I understood your question, I couldn't hear clearly, but what you're saying is that this scaling up of surgical services might be at the expense that we have limited resources and we have to give up on other things. Well, I think some of the discussions this morning were actually going to a direction which I think a lot of us would emphasize, which perhaps we, especially as countries grow and especially as they dedicate more to domestic funding of health, and as also I think the international community recognizes that investing in a health system and health system interventions such as global surgery makes a lot of sense, but perhaps there could be momentum to allocate substantial resources, not at the expense of already areas that are resource constrained.
I'm not arguing that it's not an investment and we shouldn't invest in it, but with a finite amount of money currently, which is all allocated within health, was there anything to suggest where you might draw that expenditure from? Even though we know it will give gains later down the line, it still has to be taken from somewhere now.
Yeah, I mean, I wouldn't, we didn't look at this specific case. I think it's a very sensitive question. One thing that I would argue is that I think it's an intersectoral approach as well, which I think there's a lot of infrastructure things which not necessarily should rely on the health sector. And maybe that, convincing ministries of finance and so on would be a good avenue. But I won't go into the details of the specific allocations. We didn't address this. Well, thank you very much.
All right, I'd like to thank everyone, thank our panel. Everyone's spoken? I'm not, all right. So we get a 2-minute break, and then at 2, we're going to start the afternoon.